JPS presentation, which we as a committee had requested to get their input. We'll take a 5-minute break while we get Lori to set up on her presentation. And Greg too? Yeah. Greg's going to do it? Okay. And then we'll go from there. So with that in mind, was there any further follow-up to this piece that we sent to you on questions and concerns that we still need to address? Okay, so hearing none, we'll just continue to move forward. Trent?
Yes, sir.
I think you're up to bat. I'm ready.
Yep. Well, thank you all. We appreciate the opportunity to give you a recap of the last several years of board work on this project. And on behalf of my colleague, Dr. Lowry, and all of you, I think, know Scott Fisher, D.T. Wynn has been at several of our meetings. We've had a good opportunity to stay in tune with Blue Ribbon work, and we've been giving systematically reports to our planning committee as well as our board of managers as to how the process has gone. So what we wanted to do today in response to the Blue Ribbon Committee's request that we give a board recap, to just give a little bit of where we've been at the board level, where we're going, and kind of where we believe this process is going to work. We have been very, I guess, encouraged and refreshed by the fact that even though the board hasn't been directly involved in any of the data that's been presented to you, there's been a very uncanny parallel with the work that the board has done. In fact, we've not seen one single instance of a finding that the consultants that have brought to you your recommendations have had with the work that we've been doing since 2009. So that's been encouraging to all of us that, you know, these are becoming pretty obvious needs, and there's very little controversy or disagreement in terms of what those needs are. Just in terms of a brief recap, and I will not read these slides, I'm not good at that anyway. I'll point out a few things. As you look at this, JPS has changed dramatically since the last time we had a bond election. 1985 was light years ago when it comes to what's happened in terms of our population, in terms of our care. We see over 1 million encounters a year. Now at JPS, our level 1 trauma center is the only one between essentially Lubbock and Fort Worth. So those elements of our care have grown so dramatically. Our emergency department, for example, we see over 400 people a day. 5 years ago, we averaged about 175 people. When I first got on the board, we were wondering if we could handle 200 a day, and now we are over 400 a day. So we've hit a point, I believe, where being able to iteratively increase our care to meet the need has become almost impossible because of just facility challenges that we have. We have grown, we have staffed in order to accommodate growth to the walls when it comes to JPS's current facilities. So we welcome very much the opportunity to make the next step in Tarrant County. Our contribution, and I won't spend much time on this because I think you already all know it, JPS is 6,500 employees. We have one of the most successful organ procurement centers in the country, 18 residency and fellowship programs. We have the largest family medicine residency program in the country. Other things that not on the slide that we do that matter very dramatically to the healthcare community is, as the public hospital, we put up the dollars that allow the federal funds to be pulled down for the other healthcare facilities to be able to provide uncompensated care. That IGT process is critical for all of the hospitals in our area, and JPS, as the public hospital, is responsible for making sure those occur. Another thing that we like to brag about at JPS is because of our residency programs and our fellowships, we believe we increase the likelihood of primary care physicians staying in Fort Worth and staying in Tarrant County after they've been trained at JPS. We've got folks in the room today that trained at JPS. So we're very proud of the fact that this is our bullpen, and we're able to staff that ourselves and continue to bring more and more doctors into our county from JPS's presence. Our footprint, as you know, is a bit different than some healthcare systems. You look for Dallas County, for example, it's a very different footprint of how care is delivered. JPS is always focused on the community aspects of care through the clinics. And not all healthcare systems do that. It's a bit more expensive to be able to go out there and do that as opposed to one campus. But when you talk about access and the ability for people to access our care, the fact that we now have over 40 locations in Tarrant County means a great deal. It is not very, it is pretty frequently that we hear testimony from folks that are in our school-based clinics about the fact that were it not for those school-based clinics, they may not be able to get care at all. And we continue to grow in that regard. We always get more requests for school-based clinics than we're able to fund. The more we do it, the more people are exposed to it, the more popular it becomes, and I'm sure in this next budget cycle upcoming, we'll be asked again to provide more school-based clinics. It's been a very, very popular service for us. We have 17 primary and pediatric care facilities. And again, in contrast, not all public health care systems provide that level of service out in the community. We're very proud of the fact that Tarrant County has established that as a precedent for care. You've already seen the population numbers. We have seen dramatic population increase. Again, it has taken us to our maximum when it comes to our existing facilities. We are concerned about the demographics of our population curve, especially as it relates to the aging population and JPS's ability to meet that need. We do not have the facilities to meet that need, plain and simply. You know, we spent a lot of time over the last several weeks talking about the 26% and the portion of care that JPS provides. And I want to tell you that 26% is really a product and not a factor, because that's what we're able to do, not necessarily what we would love to be able to do. We don't have any desire to go out there and try to expand into new markets or grow JPS for the sake of growth. We would like to be able to meet the demand of that population, and today we're limited to 26% of that population. So we get great care and great help from our neighborhood hospitals, from our friends in Tarrant County that also have to support a significant amount of uncompensated care. Were it not for that, I think we'd all be in a great deal of trouble. But the converse of that is, without JPS's provision of that care, what would the impact of that care be on all the other hospitals? And it would be dramatic and it would be significant. So our ability to continue to meet the need of that population really is what's predicated all of our discussions. It's not about trying to go out there and become something we're not, or mission creep, as I call it, to be able to go demand, go offer services that we had historically not provided. It's really about, how do we break even? How do we continue to serve the population that we have today? That percentage, as it grows, how do we continue to provide it? And we have met the point where that has become very, very difficult to do. Just looking at our history, this is a little pattern of JPS's growth from 1913. Our last bond election down there on the bottom right was in 1985. We still have facilities being used today that were built in the second picture from the left on the top. We still have facilities that were built in 1939, and we're still utilizing those facilities today.
What was the amount of the bond in 1985? Do you remember?
Scott, do you know?
I believe it was about 40 million.
40 million?
45. Thank you.
45
million.
Thank you, GK. So what we're talking about today has been a long dry spell since the last bond election. And as you look, and we'll talk about this a little bit more in a minute, the fact that our failure to issue debt, if you will, is a testimony to some good things. The fact is we've been able to utilize resources without issuing new debt. And that's awesome. The fact is that our valuation in our community has continued to grow to help us meet that need without issuing debt. So there's no award for issuing debt, but the fact is, as we look at other hospital systems around the state, JPS has the lowest debt-to-asset ratio of any of them. And when we start talking about the level of facilities that we need, we've got to start seriously looking at that INS portion of our tax rate, because our M&O rate has been steady, and we've provided services through M&O. We have done, in my opinion, an excellent job of being able to, not have to issue debt. But there comes a point where you pass a point of no return. Some of you recall and were around back in about 2008, 2009, about the time I came on the board. It was not uncommon to pick up a newspaper and read a negative article about JPS. And the irony of that was it was in the face of massive amounts of surplus revenues. And that's a very difficult thing to be able to defend to people, is when you're sitting on millions of dollars of surplus revenues and care is not being provided, then that's a paradigm that's very difficult to defend. And so as the board transitioned, Mr. Early came in, the commissioners kind of gave us new marching orders. What happened was we really wanted to make certain that our dollars were being used for care. And so there was no longer any joy in having unnecessary reserves sitting out there that would theoretically be used in the future to build new buildings, because those dollars were not being used to provide care. And so there's been a shift at JPS, and we don't put a lot of stock in rat-holing money. We're trying to use that money for care. But the result of that, obviously, is that when it does come time to pay for facilities, we can't go and pull $500 or $600 million out of the reserves. So the debt piece of it becomes very important. When we talk about how this debt will be issued, I can give you a couple of commitments from our board, and these are very serious commitments. One is that we will not vote to authorize anything in bond money that goes to operations and maintenance needs. We don't intend to use debt to go out there and pay salaries. We want to use debt to build facilities. We want to use debt to create capital assets that depreciate, not use debt to subterfuge operations. And so that's going to be a significant commitment. And because we keep now, in my opinion, what are more healthy reserves that reflect dollars going back into our care, the need for the debt is demonstrated. And I think it makes a good point about where we're headed and where we've been. If you look at sort of, and I know that's way too small to read, but if you look at our history at the board level of what we have done relative to facility planning, we really started this back in 2009. We issued an RFP to begin facility planning. That RFP was awarded to Boca Powell, who over the next year built a strategic utilization facilities plan for us. That process went all the way through to conceptual recommendations. We have never, and I want to emphasize this, we have never said this is the magic number that we need to meet our need. The board has never put a priority 1, 2, 3, 4, 5, 6 on those needs. What we've asked for are what are the facilities that are necessary to provide the care that we are charged to provide. And in time, we will have to figure out what that costs. But there's never been a number from the board standpoint that we've said, well, we will only work up to this number, and then we'll stop. That's not been our trajectory. Our thought process has been, we are going to understand and determine what the needs are. We're going to measure those needs against our facilities. We're going to determine what levels of efficiency we can realize that help us avoid or reduce the debt portion of this. But this has never been about trying to figure out a number. It's always been about trying to figure out a level of service. It takes us all the way to 2016 when the Commissioners Court, after reviewing our facilities plan, began this process, and I think very wisely said, let's talk to the community. Let's talk to business leaders. We had over 140 meetings engagement meetings with our partners at JPS during the board's process. The Commissioners Court then took that to a new level by appointing this committee. So we believe that in all, by integrating the Blue Ribbon Committee and combining that with all of the stakeholder interviews that we have had and the meetings that we've had at JPS, there has been an adequate amount of vetting done to make sure that the need is publicized and that people understand where JPS is. So, 7 years is a long time to be working toward an event, and we hope that we're able to see that come to fruition sooner than later. Our environment today at our system and campus level, again, our demand continues to outpace our ability to serve our patients. I had a meeting early this morning with the director of our emergency department, and I asked him, he said, Dr. Zenarosa, with 400 patients a day, what does it do to our ability to stay up with our metrics and continue to make progress on these metrics? He said, I don't mind telling you, it's harder and harder every day, because there comes a point where you just can't throw more physicians at it if there's no place to put them. And the rooms are full, and the rooms are backed up full. So we've hit that point where we've got to be able to say the environment today really is going to be best addressed through facilities utilization, understanding there's always efficiencies. There's always ways to work smarter, and we embrace that. But to be able to say that we can do this now without additional facilities, I think is, from the board's perspective, not a tenable position to be able to take. The primary preventive care piece, again, is one of those that is the most scary, just because we have so many more patients entering that age group where they don't have primary care physicians. We have always said that functionally, if we can't keep our people in panels to be able to see them within a reasonable amount of time in our clinic facilities, then it illustrates a serious problem in our system, and we are reaching that point. I want you to know that the amount of time and energy that we have put in to measuring quality since 2009 is remarkable. I will tell you that before Epic, before we had the electronic medical record system that we have today, there was a lot of unknowns about what JPS did and about how we did it. And about $60 million later, after Epic was implemented, we began to see holes in the process. We began to understand why some of the assumptions that we had were not backed up with metrics. Today they are. I don't think we as a board would be comfortable even going to the commissioner's court to say, support us with the bond campaign, if we couldn't say, here's the numbers, here's the data. And this is data that's backed up. This is data that can be supported from multiple different levels. It's data that reflects our physicians' input as well as our staff. This is not about anymore, sitting around budget and coming up with what we think would be a good metric. This is about now tying those metrics specifically to our reimbursements. We live in a world now that says if you can't make your quality metrics, you're not going to be paid. So we understand pay for performance. We live with pay for performance every single day. And our staff will tell you, and I'll tell you, I'm one of the guilty parties. Over the last 8 years of board meetings, there's very few meetings that take place where there is not some discussion relative to quality, empirical data that we can back up and illustrate JPS's need. So we feel more comfortable now than ever that when we say there is a demonstrated need, we can back that up with quality metrics and with data. And boy, have those quality metrics changed. You look at numbers of our satisfaction scores in 2009, and you ask, what that was to patient satisfaction, I can tell you folks, we were below 5 percentile, some of the lowest in the country. Today, we're among the highest in the country. We were recently awarded from Modern Healthcare the award of one of the best places to work, one of the best hospital systems to work in the country. That's not awards that go without a great deal of work. So the quality component of JPS, thanks to an amazing staff and an incredibly committed board and a committed commissioner's court, have demonstrated that this is the time. The need is now. And we're not in a position anymore of having to go make excuses because we don't have the data. We're not sure if that's the right number. Our scores don't reflect that this is a justified decision. We believe they do, and we're very passionate about moving forward with that. So what happens if we don't do anything? I think it's clear that the demographic and population growth is going to continue to overwhelm our ability to provide quality service. Our reimbursements will undoubtedly be jeopardized. We will be in circumstances where we're not able to pull down the dollars that we should because we haven't been able to maintain our quality metrics. Our inability to serve our population will negatively affect the other hospital systems. If our ED can't serve the people that are going to be showing up at our door, they are going to go to the other hospital systems. And they're not going to have a penny more to pay for that hospital care there than they had to pay when they showed up at our door. So there is an impact, and it's going to be a dramatic impact that we'll feel throughout the entire county, through all of the healthcare systems. We will experience higher costs. We are keeping some central plant elements in some of these older facilities. My granddad used to call it bubble gum and baling wire. And we're probably not that bad, but we're not far from that bad. It's when you've depreciated an asset 5 and 6 times, and you're still counting on that asset to provide reliable services. We've had some unfortunate events at JPS. We've had generators that flooded and entire floors flooded because we didn't have the backup systems that we should have. So we believe that the facilities are at a point now that if we don't do something about it, There are going to be negative financial consequences. There's absolutely going to be negative care consequences for our patient population, and ultimately negative consequences for every single one of us that use commercial providers, every single one of us that, maybe JPS is not our home hospital. But if those facilities can't provide the care for us because of the additional burden they have had to take on because of JPS's inability, then unfortunately that tide will sink and all ships will lower. We feel that JPS is well positioned now for growth. And without getting into numbers, I want to just recap quickly for you where our money comes from. Property taxes pay for about 38% of our budget. Currently, the taxes equal about $227 on a $100,000 home. That's the real impact, right down to earth, about what it costs to operate JPS today. We have the lowest debt of any large public hospital in Texas and well below national averages. We have healthy reserves, but we don't have crazy reserves anymore, and that's by design. We will no doubt be able to contribute capital to bond campaign once that decision has been made. This will not be a circumstance where JPS hasn't thought at all about what to do. We have a future fund today with about $110 million, Scott, that's about right. Those dollars have been purposefully set aside to be able to reduce the principal on the bond campaign when it comes. And we feel that to show our responsible financial stewardship of tax dollars, we need to have a plan that shows our contribution of cash and assets to reduce that principal. So that's been deliberate, but it's not to the point that we would be able to say avoid a bond campaign like what had happened in 2008 when they built the last expansion. We're not going to have that kind of cash. So we're at a point we believe this is a good time for JPS, and we are in a well positioned financially. Thank God Tarrant County continues to be amazingly blessed with a very strong population, with an economy that most other counties in this country would kill for. And sometimes I think we take for granted just how blessed we are to be in Tarrant County. But it all points to the time, the conclusion that says if there were ever a time to make a decision about expansion of facilities and JPS's ability to care for its patients, now is that time. So this is in bold bullet points where the board has lit in terms of what our priorities are well before and long before the Commissioner's Court began the studies that you guys are seeing today. We have always said that we cannot deny or ignore the central plant, the campus needs. We are completely on board with the idea that health care is going to be in the future best provided at the community level because it will reflect the avoidance of having to have somebody at the campus. And our goal is not to create more opportunities to come to the campus, but we cannot let the campus deteriorate around us. There are campus elements that we have to facilitate. We have to do that with the same diligence that we pursue the community health care clinics and those things that take the population straight to the neighborhood instead of, or care straight to the neighborhood instead of to the hospital. There's a world of people that cannot get to us. A world of people. It was incredibly gratifying this past week, and you've got the article in front of you, to cut the ribbon on the Northeast Medical Home. That will be the second medical home. And that concept is not just another clinic. That concept is to really fulfill what JPS's mission has always been, and that is let's provide the care at the level where we can help the most and not be hit with the highest acuity patients who have not been able to see a doctor. We encounter patients at JPS that are 3, 4, 6 months, a year, 2 years past the point of being able to help. And we take that charge very, very seriously. We would like very much to be able to help those people at the community clinic level and be able to see a primary care physician. And when they call to get an appointment in a couple of days to see that primary care physician. And when they leave the hospital, there's a telephone call that says, we have an appointment already set for you at the clinic, and it's next Thursday at 2 p.m. Can you be there? We've implemented those steps, and we've got to be able to continue to do that. But that new patient tower is critical. If we're going to maintain surgery, if we're going to maintain our ability to provide something as simple as private rooms, we're not able to provide today at JPS. And from the HMA report, and you all read this, they said that that tower is no longer capable of providing acute care medicine in today's healthcare world. So we cannot deny the fact that there are dramatic campus improvements that need to be made, but we don't do that to the sacrifice of the concept that we still focus on the local delivery in the neighborhood to really make the best impact. Ambulatory facilities. This is one that you all, thankfully, have spent a great deal of time on. This is one that we at JPS, frankly, were a little nervous about because we understand how important an ambulatory care surgery center is. But because of the cost of ambulatory care, it's one of those that becomes very difficult to keep up there at the top of the list. We desperately appreciate the work that you all have done in illustrating what that ambulatory care model is. And I'll talk a bit more about that in a minute. And the psychiatric hospital. You've heard Wayne, you've heard presentations about why that piece literally, that floats every single boat in Tarrant County, folks, because that need is so dramatic. And we feel a little bit like the Lone Ranger when it comes to providing that care, that inpatient care. We spend a great deal of money having to contract out to go find people to help us provide that care. And unfortunately, they are not willing to do it for the same price we do it for. So, we're going to continue to try to meet the need. But when you talk about psychiatric care, there's probably no more demonstrated need anywhere in Tarrant County than that. So I've talked a little bit about the patient tower, the capacity issues, the quality and satisfaction issues. We're very proud of the fact that we have a very engaged physician staff now, a physician staff that feels much better about where JPS is today than it felt 10 years ago. And I think interviewing any of them would back that up. The operational efficiencies that we will realize simply from not hauling gurneys across the street, for example, which is some of the things that we do today, give us really, I think, a good trajectory on supporting a new patient tower. The psychiatric hospital, as I've mentioned, this is a life and death issue for us just from a safety standpoint. We have our psychiatric patients in some of the most untenable places you can imagine. How many of you have been on the tour, got to go on the tour? If you've seen that, then you understand. I don't have to tell you just how critical that need is. And boy, I can't tell you how proud I am of our psychiatric staff. I mean, Wayne and his folks have done an amazing job of providing care for those facilities. And Wayne, thumbs up, because he continues to do it. His staff continues to do it day in, day out. But there's a point where we have to say, Wayne, it's our turn. It's our turn to come to the table, because we're going to have to get you some facilities to be able to continue operating that care. On the ambulatory side, our capacity, our medical home, we rely on that as being one of those things that keep people out of the hospital. That concept is going to continue to grow. That facility in Euless is going to be like the facility in Arlington, and hopefully we'll be able to replicate that. When you talked about the ambulatory priorities that came from HMA, you saw 4 additional clinics. We don't want to build a clinic unless it has that patient population program that says we are going to focus on population health. We are going to try very hard to get people out of the emergency room and have a place locally where they can be served. Our ambulatory surgery center, and again, we appreciate the work you have done on that. We think that because of our surgery demand, this is a particularly important aspect for us, because we can take our turn time in a surgery suite from 25 to 30 minutes down to 10 to 15 minutes if we've got sufficient ambulatory surgical centers. So it's an expensive component, but one that would very certainly pay great dividends to us in terms of our patient care and our ability to continue to meet our own metrics. The stewardship of assets, there is no way for us to continue to be able to provide ambulatory care at the level we provide today without additional facilities. And I mean at the level we provide today. It's not just that how are we going to meet the growing demand, it's how are we going to meet the need today. So the ambulatory care piece, we are completely aligned with you and with the report that you've seen on how important that is for our future. I've mentioned, and I'll conclude with just a couple of more remarks, I've mentioned that we at JPS put a great deal of stock on metrics and about quality and about being able to justify and prove up what we've asked for based on real data that really is not arguable data. These facilities if provided for Tarrant County, we believe will give us a comprehensive and integrated plan unlike any that's ever been in Tarrant County before. We believe that it can be done with minimal impact on the tax rate. There's work to be done on that, and at the end of the day, what we want to be able to do at the board level is work very closely with the Commissioners Court to make sure that we found that balance between providing the care, making certain that the resources that we're going to apply are used wisely, and that we have done it in a manner that reflects what the county needs as the paramount concern, not necessarily what the tax impact's going to be. But you can bet this is all going to be done in light of the resources that are available. None of us on the board are thrilled about the idea of bringing huge tax increases. We've all been on there too long. We know that environment. But the fact is, we don't want that to be the guiding principle. We want the guiding principle to be the care that we provide, how we've improved care in this community, how we've made Tarrant County a better place. But I believe you can trust your commissioners. They've demonstrated that trust in the past about using these resources carefully and applying these dollars in a way that we think will provide the best benefit for us. So as you look, I mentioned earlier that, you know, when you see the true numbers about where Tarrant County is in terms of its debt and our capacity, we are very fortunate not to have a great deal of debt, and we feel that positioning really best takes advantage of a very low interest rate market that we continue to enjoy. You know, we continue to put these things off, and eventually interest rates start to climb, and we pay much, much more dollars for the same thing. Remember, we started this back in 2009. The cost of construction alone since 2009 is seven-figure numbers. So we believe the time is right. We will continue to work very closely with the Commissioners Court on making sure that whatever ultimately is in the package reflects a concern for the recommendations of this committee, which we see as paramount, our financial capacity at JPS to continue providing care, the contribution of reserves in a responsible way that still keeps us above our reserve policy, and if there is an impact on the tax rate, that will be dealt with, and we will mitigate that accordingly. So, in summary, we've been working on this a long time at the board level. Really, 2009 was our kickoff point. Our goal has never been to expand facilities for the purpose of providing new markets or creating new commercial pay bases. Our goal has been to be able to provide the level of care to the patient population that we provide today and at least stay up with that and not get further behind. Our work has been geared toward reducing the need to come to the hospital. We continue to focus on that as our primary objective. We want to continue a culture of quality and compassion. We will continue to measure every single thing, every single day. We know that our reimbursements are directly tied to that. We feel that we would be literally acting in conflict with our core mission to do nothing at this point. Because if we can't provide the level of care that Tarrant County has come to expect for this population because of facilities, our core mission is in danger, and we will not be able to make it. We will work very closely with the Commissioners Court. We will take into consideration this committee's recommendations very strongly and look forward to being able to bring that to fruition. Finally, from the Board of Managers, on behalf of Dr. Lowry, Scott Fisher, who was on our board for many years, Chair, D.T. Wynn, who's been here many times, we appreciate the work that you put into this. JPS is the benefactor, and we're a blessed benefactor in that regard. Your efforts have been applaudable, and we appreciate it. I know it takes a great deal of time and energy to come down here and sit through these meetings. You know, we like to joke at the board level, we get paid in cookies. You've gotten paid in cookies, just like we do. And we appreciate that time, we truly do. So with that, I'll conclude. Mr. Chairman, Madam Chairman, if there's any questions, I'll be happy to answer them. Thank goodness I have my staff surrounding me. They can help me out of a bind if I get into it, but I'll be happy to answer any questions.
Trent, thank you. It was a great report. Yes. While we've still got you here, I know that you've got another meeting you've got to run to, so while we've still got Trent here, does the committee have any questions for him? You like him to elaborate on any part of his presentation?
Could you do it again for me? I just
Yeah, Mr. Chairman, I do. Trent, I'm sorry, I'm not gonna let you off that easy, okay? Would you walk us through a few things? First of all, I mean, I assume that we're gonna make recommendations. Are they going to the Board of Managers for consideration, then to the County Commissioners Court? Is that,
The hope. The
that would
hope-
be the hope, okay?
That's right. We would like to take the Blue Ribbon Committee and vet that ourselves, so that when
Okay.
it does go to the commissioners, we've provided them all of our backup. Our staff has done everything we can to make sure that the data is reflected, and then we will be able to sit down with the Commissioners Court and be on the same page.
Okay, so in that case, would our recommendations need to include anything other than just facilities? Does it need to include timelines, financing, any of that?
I don't think so. I
Okay.
think if the Blue Ribbon Committee, through your scope, can focus on, has it been demonstrated to you that the facility needs that you have seen can be met with these steps, then I think the timing and the amount become really something we have to rely on the court to help us come up with. So I don't
Okay.
think we're asking for anything more than that.
From
at
that,
this point.
okay, so you don't want us to consider tax rates, financing, any of those issues in terms of what we're doing?
No, because at this point in time, I'm sorry, I should be holding this. At this point in time, that would be premature even from our standpoint. Again, we don't have a magic number in mind. All of us have talked about what this might be.
Right.
But until we can really sit down with our financial advisors and look at exactly how this would be phased and how that debt might be issued, we can't really articulate that in terms of a tax rate. And I apologize for the fact that it's difficult to be on a committee like this in your position and be asked to vote for something that I can't give you the exact cost or the exact time frame on. On that point, I'll just ask that you just trust us. Trust your Commissioners Court and trust the Board of Managers, because our interests are yours in this. And we've got to be able to do it in a way that's vetted, that's correct. Saying something now would put us in a position of having to defend it, and if it's wrong, we're all gonna have egg on our face. So we'd
Thank you.
like to be able to put that off and get that vetted correctly.
Yeah, and I have another one. So, okay, that helps me, and I hope the committee understand what our scope is, what we're needing, or being asked to do. And so you've got $110 million sitting in reserve, and that's gonna be up to you guys to decide about that, decide what else you put with it. That'll be the Board of Managers' decision, all that, right?
A recommendation to the Commissioners Court, that's right.
Okay, good. So, are you speaking for the JPS hospital in terms of the facility recommendations? I mean, we had asked specifically for, what does the hospital want? What does the hospital staff or operations staff want? Is that
I
what
am.
this is?
I
Okay.
am.
And so
This-
your recommendations matched up. Basically, what you just said was, we agree with our consultants' recommendations.
We do.
But you didn't talk about any of the options within those. Is there something needs to be said about those?
We have not, when you look at the big spreadsheet, for example, that says these elements could be added, and we'd recommend the consideration of these elements. I cannot speak on behalf of the board on those elements because they've not been presented to the board.
Okay.
The only ones that know about that are Dr. Lowry and I.
Okay.
And so until that can go through the board and can be vetted against the resources that are gonna have to be applied to it, I don't wanna speak for the board on things that they haven't seen. And there are components of this that the board has not been formally presented, so we will not try to speak for them on that point.
Okay, so we would need to include in our recommendations the options then?
Yes. If Blue Ribbon Committee believes that the options are viable, then we would love to be able to have Blue Ribbon Committee's full recommendation. And to the extent that that recommendation has to be parsed in some way,
Okay.
then at least we know what Blue Ribbon Committee's feelings were
Okay.
about that and the importance of it.
Okay, great, thank you.
Yes, sir.
I think we had a question, was it? I thought I saw a hand.
Yeah,
Was it you, Andy?
Trent, can you elaborate on the ambulatory surgical center? How is that different from the medical home? Is it expected to be a part of the medical home?
Now, the intent would be for an ambulatory service center to be on the campus, because we want to be
Okay.
able to take advantage of reducing the impact on OR, for example, where we're having to take up OR space with ambulatory cases today. That would remove that. And so the intent for the ambulatory surgery facility would be somewhere on the campus. and it
Somewhere on the
is-
campus.
It is designed within the facilities plan. And by the way, if you haven't had a chance to look at the JPS facilities plan that Boca Powell did for us, it is on our website. And we'd be happy for you to go out there and take a look at that. But no, this would be a central surgical ambulatory facility on the campus.
Okay, thank you.
Yes, sir.
Trent, I had one question for you, even though it won't have any impact on how I'm gonna be voting. I'm just curious. Do you feel like, if indeed this all goes through, do you think we'll be at a triple-A rating on the bonds, which would obviously be the lowest interest rate then? Do you feel pretty confident about that?
I do. We work very closely with David Medens and Hilltop and our financial advisors to make sure that we protect that. I would be very surprised. The only thing that we don't control about that rating would be at the time of issuance is if there is some gigantic uncertainty accompanying the macro healthcare delivery in this country.
Yeah.
We can't control that. But when it comes to what we can control, being able to reflect the stewardship that has resulted in that bond rating today, we intend to keep that.
Good, thank you.
And just tell us how long we've had that AAA rating.
As far as I can remember, I don't know the genesis of it, Commissioner, but as far as I can remember.
Good.
Yeah, JPS, the county has done an amazing job of financial stewardship at JPS. I wish I could say that JPS has always been the care steward that we should,
Yeah.
but I do believe we are now. Yes, ma'am.
Mr. Petty, I very much enjoyed, well, enjoy is probably the wrong word, but I had a professor at Jarvis Christian College who said you have to be clear, clean, and precise in your work.
Thank you.
What I am trying to make sure in my mind, what you want this Blue Ribbon Committee to do is kind of ratify, or, yeah, maybe ratify is the word, the usage, where you as a board have already seen you need to go. So, we looked at all these reports from consultants, and we've been and visited and all of that. And so you want us to help ratify the direction and the use based on our increase in population, our limited resources. And I guess my other part of the question is there a mixture? You talk quite eloquently about the balance between what you're spending and the usage that you're using the money for. Is there a formula where
No, I
you
don't-
break even, kind of?
The first part of the question first. I do not believe it's the board's intent to ask this committee to ratify the board's findings.
Okay.
I do believe it's the board's intent that you agree with or not agree with the consulting study that has been presented to you.
Okay.
The beautiful byproduct of that is the fact that they are almost perfectly aligned. And so the result is exactly the same, Madam Chairman.
So
but
we're extra eyes,
we
extra
are.
eyes of.
And that's been the gratifying piece of this. As we went through our facilities planning, what we heard from these consultants was not only were we right, but if anything, we didn't go far enough. And that's understandable when our presentations were back in 2015. That 2 more years of the multiple effect of not having facilities shows up, and it's shown up in these numbers that you see before you today. And it will continue to show up. So I do believe that we will appreciate ratification of the consulting studies that have been presented to you, and appreciate the fact that JPS has been headed down that same road.
Okay.
As to the second part of the question, I do not believe there is a formula per se that we can academically apply to this to say this is the right number. I absolutely believe there is a moral formula. I believe at the end of the day, Tarrant County looks in the mirror and they say, how important is this population of people to our county? And when we can do that and we're happy with the reflection that we see, I think we got the formula right. And that's a hard answer, and it's not an empirical answer, but I think it's a hard issue. I think we're at a point where we will be able to create the empirical formulas that warrant and justify the expenditures. Without a doubt, we will be able to do that. But we got to do the right thing. And if we do the right thing, I think we're all going to realize we had the formula correct.
And I think that's something I think this Blue Ribbon Committee wants to do, the right thing. Yeah. For our folks. Thank you.
Yes, ma'am.
Other questions for Trent?
I had one question for you,
Yes, sir,
Trent.
Dr. Simmons.
Getting back to the ASC idea, has there been any consideration to also maybe an ambulatory procedure center, which could further decompress cases that don't necessarily be done than ASC and provide it in a more efficient manner?
Not at the board level, but I know at the staff level, that discussion is taking place. It continues to take place. And I think within that entire ambulatory services paradigm, we've got to be able to look at what those additional steps may be. And that's one reason I'm reticent to light on a number or a particular recommendation at this moment, is because once we finish with the Blue Ribbon Committee's recommendation, we want to take those things back and vet them and see maybe there is additional benefits to be derived from that type program.
Roy, you have a comment?
If I say no, will everyone be surprised? I think our hospital system has avoided accusations that we've tried to rush into anything. This has been a very studied and careful plan. Clearly, you look at it with a conscience and you say, gosh, why didn't y'all ask for a bond fund 10 years ago? And maybe we should have. But we've done our best, I think, to study all aspects of this, including places like Maricopa County, who compare very positively to Tarrant County and how they've made a successful run out of their deal. The other sad reality of this, and excuse me, Trent, you've done a beautiful job. The sad reality is there are people who are going to vote against this just because it's about money out of their pocket. And the conscience part and the look in the mirror part is what I'm going to agree with. I think this board has gone about this in all the right ways. We're saying, may I, in the kindest way, and I think we're going to proceed one way or the other. It'd be real nice to have y'all's support. Is that okay?
Okay. Anybody else? Going once, going twice. Trent, thanks again. I appreciate it. Okay, Greg, I think, who's doing the comparison of the? Okay, okay. Yeah.
Answering one part of the question.
Yeah.
It might be, yeah. So if everyone takes a look at this package here, that had the questions and concerns, and goes about halfway in, you're gonna find, this chart, which you're looking at up here. It might be difficult to see up here. So these were, just a few of the questions around, how do we compare to other like counties, like, systems? And one of them was around what percent of uncompensated care does JPS provide across the county? How does that compare to other counties? And the short answer is, looking at this, that it is very comparable in each one of those 4 counties, right? So we have Parkland, Harris, and San Antonio University Health System. And they're all just a little above or a little below 50%, showing that those are, you all are incredibly important to the counties and to your communities to provide that uncompensated care. And as Trent was saying, important to those other health systems because you're taking on that care. Similarly, when we're looking at the percent of Medicaid, those are coming in around near the same. They're going up and above and below the 23%, which is where JPS is, but still around that range and relatively low on Medicare, and they're below 5% or around 5%, except for Harris, which is lower on both Medicaid and Medicare. So very comparable across those health systems.
Can you explain the Medicaid days? What does that mean? What does that metric
Yeah, so
mean?
when we have just the kind of volume, the number of discharges, how many are
How many-
discharged from that hospital, and then there's a number of days that each one of those discharges represent. So when there's a higher percentage of those Medicaid days as compared to the discharges, there's a longer length of stay.
Longer length, right?
The longer length of stay. That's making the Medicaid days come out different than the, so here.
So the smaller the number, the better? Is that?
Yeah, I mean, these are comparable. In other words, on 22 versus 23.3, we see that the number of days that the Medicaid patients are at JPS are similar to other hospital systems across the county, because they're coming out the same, those two numbers.
Okay.
That's not the case in some of the other counties. Where
I'm trying to understand, comparing between JPS and Parkland, for example, it's almost double on the Medicaid days. What does that mean?
Right, so
What are-
longer length of stay as compared, at Parkland, longer lengths of stay for Medicaid patients as compared to the rest of the county, the rest of the hospitals in the county.
Okay,
Now, that
so the
could be for
Medicaid
various
patient
reasons.
stays longer,
Yes.
almost twice as long at Parkland than they do at JPS.
So they are about 50% longer than their compatriots, than their other hospitals.
Okay,
And JPS is the same,
gotcha, okay,
is how you might look at that.
okay, thank you.
So, about 50% more. So that's the difference. There could be a lot of reasons for that. So this is not an in-depth analysis of whether that's good or bad, but this is saying that these are.
Generically speaking.
around similar- Yeah, yeah, and that's a good thing, to have good lengths of stay. And it's also something that, if the uncompensated care was much higher, you would be hand-wringing about, right? You want to have that be in a reasonable range, and yet you want it to be enough because that's the mission. So you're in the range of others. It seems to be, a reasonable place. Let's see, we have one other, oh yeah, okay. So this was another question around, this is on your next page, around revenue breakdown. And if we look down on the percentage of revenue, so really on the bottom part is where you see how much of these different categories, this is the pie chart that was presented as well by Trent, that if we look across, these numbers of net patient service revenue and Medicaid supplemental funding added together are very similar across the system. University Health System does not report out the supplemental Medicaid funding separately, and so it is very likely tucked underneath that 65.9%, but not sure how that breaks out, because it's not, this is publicly available data. And on target as well as far as the property taxes, and we've seen that presented in various ways, but on target there as well. Any questions on these quite comparable?
On the net patient service revenue, are these numbers taken from what year?
So I believe these are 2016, yes.
2016.
Not up here, but yes, these are kind of publicly available numbers for 2016, yeah.
So would you attribute the difference between the net patient service revenue of JPS and Parkland to the fact that Parkland has a much larger, newer facility? It's basically double?
So the net patient revenues are about the same, though the budget's much larger. So
Right.
the percentage is much lower at Harris Health System. And we didn't look into, why that is. They have higher, if we look back, they have higher uncompensated care as well.
Right, they do.
Yeah, which would, be one of the reasons why potentially net patient service.
I'm trying to figure out the correlation between the two. You see what I'm saying?
Yeah, so,
Okay.
More uncompensated care, less net patient revenue, more of their activity supported by supplemental funding.
Okay, thank you.
Can you go back to that prior slide? So that, I'm still kind of stuck like Commissioner Wynn on some of these numbers, but when you said the 45% is the percentage of the uncompensated care, that first column?
Oh,
That
Yep.
JP,
uh-huh.
now say that goes down to 35%, does the rest of that just drop off the map, or does it go into the,
That would be to other hospitals.
do they automatically pick it up? That's what I'm trying to.
Yeah, because it's 100% of the uncompensated
Okay,
care
but-
across the county, so. we would-
Well, I understand that principle, but
Yeah.
I'm really talking about the human beings. If someone,
Yeah,
if JPS can't fill up to the 45 in the future,
yeah.
does some of them fall off the grid, or do you think they all find their way into
I think
private
we
hospital?
Right, so the community health need assessment, and the current data would suggest that it's a combination, that there really are, unmet needs out there now, and to have any pullback would create more unmet needs. People,
But they'll find their way to a private hospital, though.
some will, absolutely.
Yeah.
So it's kind of a combination.
Okay, thank you.
I think,
And
don't you think though, the vast majority in an acute situation, they know to get to a hospital or call 911, and so if JPS is closed, they're gonna end up down here at one of the other
Exactly.
hospitals.
Emergency room,
Yeah.
way
Yeah.
up. So when you talk about, maybe ambulatory primary care, some shift there, but on the acute, absolutely, all the next place.
But landing in somebody's emergency room is not the same thing as getting comprehensive care. When patients without resources land in a non-public hospital emergency room, then the responsibility of that hospital is stabilization.
Well, it's stabilized, and it's
treatment
also to
too.
treat if they have the capability to treat. So for instance, if a patient ended up in a hospital that did not have an OB program, so mom's in labor, they don't have anybody that can deliver that baby. So they're gonna stabilize and get that lady to the nearest women's program if they can do it safely. However, if they do have it, then they have to treat, and they have to treat it exactly the same level as anybody else that comes in that ER. That's the old EMTALA law from the, 86, I think, is when that was first put into effect. And I can tell you that there are exceptions, but we're talking less than 1%. That's one of those laws that hospitals do not like to cross. There are very hard ramifications for a hospital that does not treat a patient that they are capable of treating, whether it's cardiac care, orthopedic care, whatever. Now, to get to your point, a lot of the trauma that JPS takes care of, these hospitals could not take care of. They just don't have the capability. So there's kind of a mix there.
I would submit to you that delivering a baby is different from providing continual care for a chronic disease, and that's not likely to happen.
Now, chronic disease, that's a whole different group of patients, for sure. So I
But
agree
it
with
is
you.
a group of
I agree with
patients.
you on that.
Yeah.
Yeah.
Diabetic that shows
Yeah.
up to the ER and sure is stabilized, sent out.
Kinda
and they
clean
get
'em
a
up.
hyperglycemia,
Yep, and then
event.
on out, yeah.
Absolutely.
Yeah. So point well taken, Commissioner.
Okay, so one other thing that was asked about is this kind of percent of need on the primary care side. And really this is resources available. So this is looking at what kind of primary care capacity is there in each one of these counties. And that primary care capacity applied towards that population in the county, how much of the under 250% FPL could that capacity serve? There are a lot of assumptions across these, other health centers, things that we did not look at or control for. So we should just keep that in mind, that there may be a much different payer mix of University Hospital, for instance, that just is not in here. Is that capacity being used for that population or not? So that part's not in here. It's just saying, here's a capacity that these systems have, and if it were applied towards that population, what would that look like in each one of those? And we do see that, there is, there's a disparity we see there, that there's a lower amount at the JPS, the capacity currently available for the population. Again, there may be a lot more of that put towards the 250% FPL, so that part of the comparison has not been done. We're missing the one other, but if you could see it, and I'll put you ahead one more slide here in your papers, and it's this one here. And what that's showing is really the one next biggest FQHC. So there are other sources of primary care, particularly for the under 250% FPL, that's available. And this is saying, okay, that one next largest FQHC, how much capacity are they bringing And so this just tells you a little bit more about what percent of the population is covered in that particular county. And it does, as you see, and there's assumptions here as well. This is built entirely off of revenues and not looking into their actual delivery of care. It's assuming that a certain number of visits can be done or are being done based on revenue. So these are very high-level looks at this, but certainly there is a lot more primary care capacity at the 250% FPL in these other counties. Arguing, I think, putting more weight towards what you've already, kind of put weight on, which is building up more ambulatory capacity.
So I want to reflect on the number that you asked to go back to, please, for just a second, and that is if you take these numbers, the old statement that figures never lie, but liars sure can figure, that's from Poly High School. 1967, but who cares? Anyway, JPS is shown as 45% of the county uncompensated care, and the other hospitals are 54.6. Well, you think, well, gosh, JPS isn't much doing their share. Please refer back to that there are 39 hospitals reported. Divide that 54% by 39 hospitals, and that means each hospital is providing about 1.25% of uncompensated care, and JPS is providing 45%. That makes that fraction look real different. And I can't say that the 39 hospitals are equal in what they do, but it really states to the fact that they're not. Stuart Flynn told me one time that in Arizona they talked about how, well, we're all providing our uncompensated care. If you look at that number, they look like heroes. And yet the fact is, the real hero here is Trent's group. So.
Huge percentage of one
Yes.
hospital, yes.
Yeah.
Other questions or comments on the rest of the answers that were in the packet?
I'm still struggling with the revenue breakdown. Can you help me clarify this? The revenue from Parkland compared to Harris is more than 300 million. How could that be? Harris is a lot larger. And then if you look at the other table, which basically shows Parkland percentage of county uncompensated care cost is about 60%, compared to Harris is about 52. So the difference there is only 8%. So the revenue projection, it just doesn't add up to me. It doesn't.
Yeah, so here what you're saying is you're seeing a large percentage for Parkland in the uncompensated care. Large percentage, and then when we're going here, we're
Would you look-
seeing a large net patient revenue service line. And those are the two pieces that you're saying.
Right, and Harris County is a larger county.
Right. Right, they don't have as big of a, total revenue as Parkland, per the publicly available data.
Okay. Which seems odd to me, but I'm just,
Well, I wonder about the Harris health system too, in that, you have the medical center down there in Houston, and you have, I think, 2 or 3 level 1 trauma centers all through that area. I mean, they're within blocks of each other. And I don't know if that breaks it up in some way. I mean, I'm just saying, what you look at DFW, you got Parkland over there, you got JPS here. You go down to Houston, and everything is centralized towards that medical center. And I don't know if that changes the dynamics of it or not. I really have no idea. I mean, has anybody worked, have you worked down in the Houston area, Scott, or anything? I would think in some ways it has to change the dynamics of what goes on down there, but I don't know.
Yeah, and certainly in in Harris and Houston, there's a lower percentage of Medicaid and Medicare to support their activities, which then, results in this kind of higher tax support of 48%.
Right.
So
Which is-
those pieces anyway hold together. But I hear what you're saying on this particular piece of the net payment revenues perhaps being larger than one would expect, given the numbers here for Parkland. I don't have an answer for why.
I know, I'm just want to make things a little bit more confusing.
Mission accomplished.
Yeah, got it. You got that done.
So this means JPS is doing okay.
Doing very well. Yeah, within the community, it's a very important provider of the uncompensated care. And really doing it in a way that's still drawing in significant Medicaid and Medicare to support that mission. So, I think in terms of balance and how that compares to the others, that is on target.
Well, and just so everybody can understand, there's been conversations amongst some of us on the board and administration, how to better service this ambulatory care portion. And the medical care homes are great and terrific, and it's sort of complex to get one going. Trent, y'all took quite a while to get that one developed. And so, in places like Alameda County in California, they can forgive me for taking license with them, but they're trying new things. Where's the best place to locate clinics? Schools are great because they're in every other community. Guess what else is being tried and we're looking at right now? Fire department guys will be calling each other tonight, but guess where the fire stations are? Right in the neighborhoods. If you can winnow off from a fire station with a primary care clinic without developing the complete medical home, you provided another service care center. So we are using our imaginations here, some of us, to see where we can go next. I don't want to read about this in the paper tomorrow that I said we'll be using fire stations. My house will be burned down tonight. But you have to get creative with this. And the medical home, as ideal as it sounds, is not going to solve all the problems. And if you just got to go to a local fire station to get your blood pressure checked, or to check your diabetes and your sugar levels if you're not so good at it, how handy is that? So we are still looking in our system at other options.
And that gives more personnel, medical personnel out there, because usually the EMS people know how to do this stuff. Or with a minimal amount of training,
Well,
they can,
the facility becomes used by two parts of our community, fire protective services and our hospital. And you're gonna staff it with a nurse and physician level, or equal, PA or nurse practitioners. So it's just one other thought, and I just share that because I want y'all to know, we're not just wondering, well, how many medical homes can we build? We're looking at other distinctive options, cost effective.
Just parenthetically, the CEO that built the Alameda County system trained at JPS.
Huh. Yeah. Okay, so no more questions for Greg on
Greg, you skate. Good job.
That's a tough one, because I know those charts, everybody's counting the data a little bit differently, and it is just so hard to make a apples to apples
Yeah.
comparison, but thanks
You
for,
really have to delve in
yeah,
more
After this.
detail.
yeah. Let's take a 5-minute break as Lori gets all ready to go, and we'll be right back. Not allowed to vote because they're just liaisons. So this is probably my last meeting here, because when you have to tell two commissioners that they're not allowed to vote, I suspect I'm going to be booted off of this. So it's been nice knowing y'all.
I got your back.
I just want you, you got my back? Ooh, okay.
No, I have to buy you more cookies. I don't have to vote. Less pressure.
And Roy, my good friend Roy, I'm sorry I gotta tell you no too, because you're on the board. But at the end of this, we would like your input in the event we have not covered something that you really would like to, inform us about. So with that in mind, Lori, it's all yours.
Yeah, I wanted to start by saying thanks to Ms. Miller for bringing the committee back to the purpose that we're here. So I just wanted to read a couple of bullet points from the charge of the committee so that we're really clear about what we're doing here this afternoon. So it says, working with the committee's liaisons from the Tarrant County Commissioners Court and the JPS Board of Managers, County and JPS Health Network staff, the committee is charged to assess the current and projected community health needs of Tarrant County and recommend strategies to improve the health status of residents in an effective, efficient, and measurable model involving diverse community and healthcare services stakeholders. Next is, in light of changing demographics, assess the current and projected healthcare delivery system's capacity to meet the current and projected population demands, and recommend collaborative partnerships and collaborations between JPS Health Network, non-governmental healthcare providers, community agencies, and civic organizations. And the last one that we're going to focus on today is come to a conclusion about the need to fund and implement the JPS Strategic Facilities Utilization Plan and Capital Construction Project, including recommended revisions to those plans based upon community health needs in Tarrant County. So that's really what we're here to do today. And what I'd like to start with is just by clarifying HMA's recommendations to the committee. So the committee is going to be putting together a report that really speaks to your collective recommendations and bringing that forward, to the Board of Managers, to the County Commissioners. And I want to make sure that we're clear about what those recommendations are, and these are the recommendations from HMA. So I'd like to walk through those briefly and make sure that folks are on board, or if there are any concerns about any of them, that we make sure that we have the time and that we create the time to talk about those. And that's what that parking lot is for. So right now I'm going to walk through these. You can just ignore that for right now. These include facility recommendations as well as community-wide or Tarrant County-wide planning efforts. So the first one is the new main hospital. So John Peter Smith Hospital has functional limitations and capacity concerns in light of a 46% growth in population over the next 40 years. A lot of this is going to be repetitive to what Trent had talked about. Again, our recommendations and where they have been going is very much aligned, and it was a relief for us too. So HMA recommends the construction of a properly located and sized patient tower to meet the future needs of Tarrant County. So that's the main hospital. We were asked to address trauma services as well. So looking at, JPS has the highest level trauma service. It's a level 1 in the county. We know that in the coming years, and not too distant future, there'll be a need for another level 1 trauma center. But our recommendation was to have JPS partner with new entrants into the market and lead trauma services planning for the county, but to continue its current level of service and invest in strategies to reduce trauma. Trauma is expensive, and it's to be avoided. So to reduce trauma incidents such as substance abuse prevention and treatment. So it's an example of a place we think effort should be placed. Okay, so that's the main hospital. Ambulatory care infrastructure. So Trent talked about this. He talked about shifting the emphasis from hospital care to ambulatory care to community care. That concurrent development is crucial to reducing the demand for inpatient services, so we don't have to build a mega hospital. We really want to focus on taking care of people in the community to prevent the need for hospitalization. This will save overall healthcare costs and provide access to coordinated and cost-effective care in the community. So HMA recommends an increase in the number of full-service neighborhood clinics, or primary care medical homes is what JPS refers to them as, and integrating behavioral health and dental services to the extent possible into those and I think the newspaper article talks about one-stop shop, and to the extent that we can do that in the community, that will benefit the residents. Other ambulatory infrastructure, such as space for specialty services, a new cancer center, an ambulatory surgery center, or a day surgery center are to be considered in the overall ambulatory care plan as well. The next is a psychiatric hospital, and we heard overwhelmingly from community members and from stakeholders, CEOs of other hospitals, that the psychiatric resources are is an incredible need, and that the costs and tragedies that occur in the criminal justice system, as well as other social costs, are a result of not having a robust enough infrastructure in mental health in the community, and as well as hospital space. JPS, unlike other hospitals in the county, is really equipped to deal with the most complex behavioral health patients in the county, and those other hospitals really rely on the county. So Trinity Springs Hospital has significant limitations. They can't adequately address them and meet the needs of persons with behavioral health diagnoses in the coming decades. So it's tough to do it now, and as you know, they're basically paying other hospitals to take care of these patients. But as we look at the next 20 years, it's really going to be pretty much off the charts. So HMA recommends a replacement psychiatric hospital with expanded capacity and centralized services that improves the ability of JPS to meet the growing needs of the county residents. Just like we talked about community or neighborhood health centers reducing the need for hospital beds, so too we're looking at a behavioral health infrastructure in the community that will reduce the need for psych hospital beds. So shifting the emphasis again. And really focusing on community-based behavioral health programming and integrating behavioral health services in existing, to the extent possible, and all future neighborhood health centers. We further recommend that JPS lead a county-wide planning effort related to behavioral health system of care that includes key partners to ensure a robust outpatient behavioral health service, substance abuse services, jail diversion programs, and strategically placed psychiatric emergency centers or kind of acute evaluation centers, so that not everyone in the county who's having an acute behavioral health need needs to come centrally. And those can be built into other existing ambulatory centers. The next one, and on page 2, and you all have this in your packet, is integrated delivery system. So JPS Health Network is an integrated delivery system. They have tertiary care, which is hospital care, specialty, primary care, behavioral health, so it runs the continuum of care. And our focus is, and nationally we do this across the country, is to make sure that those systems are tightly integrated and that patients are managed well between those across the continuum. Particularly because of, for health outcomes, but also because payment is changing. And Trent talked about this. He said we have a lot of pay for performance, or if our quality is good, then we get, incentivized for that. But as we move into the future, more and more payment is going to be like that. It's going to be pay for value, not pay for, a particular service or a particular procedure, right? It's going to be an overall or global payment. And the better you can manage your patients and coordinate the care of your patients, the better you'll do financially. So we think that can be strengthened. It can always be strengthened. There's always room for improvement. But also, we're suggesting that JPS consider working with existing partners and potentially new partners as they enter the market to look at coordinating care between disparate health entities. So not just within the JPS health network, but looking at other systems of care, because other low-income, uninsured patients are going to those other systems as well. And how can we work together with some of those other entities to best coordinate care and manage care for those patients? And there are lots of ways to do that, and we can talk about that at a later point. Next is workforce. I think we all recognize that JPS is a vital contributor to the education and training of future healthcare workers, physicians, and other healthcare workers in the county. There are federally designated shortage areas, for health profession shortage areas, medically underserved areas in the county. These are only going to get worse with the growing population. We know that we have one medical school, a second one is coming on board, that those feed into local residency programs. And while JPS has residency programs, they might seek to look at an internal medicine residency program or expand those residency programs for other, specific areas. Because once you get residents, they are likely to stay, if you treat them well and they fall in love with Fort Worth. The next one is elder care, or looking at how the population ages. JPS is going to need to build capacity across the continuum of services for elder care and primary care and behavioral health and in specialty care and inpatient care, and work with others in the county to assure adequate long-term services and support for seniors. And the last one is prevention and social determinants of health. So how do we keep the need for more acute care down? Well, we can focus on community prevention, right? And we know that there are evidence-based models that really can impact that. So we recommend an emphasis on prevention and addressing social determinants. So looking at a more formal and strategic alliance between JPS and Tarrant County Public Health, who is charged to do with much of that work, and a countywide planning and implementation effort to prevent health conditions that are of high prevalence and cost that are amenable to change, like diabetes, like infant mortality, like other things that folks are working on already or may need to work on soon. Social determinants of health, and what I mean by that, and we've talked about this before in the committee, often looking at policy efforts. So having JPS weigh in on policy efforts related to health and health status that may be directly or indirectly related. So it could be smoking, nutrition, physical activity, access to healthcare services, including transportation, lots of social determinants of health, but we all, kind of collectively need to be working on those. And as much as JPS can lend its credibility to those efforts, we think the better. So those are all of the recommendations, facilities and countywide planning, that we have in our 250-page reports. This is just distilled down into 2 pages. So as you look at those, I'm going to take the facility planning pieces out of that for right now, because we're going to talk about that shortly and we're going to vote on that. But these are what's left. So countywide behavioral health, integrated delivery system, as I started talking about before, a collaborative plan related to workforce and health professions training, elder care and geriatrics, and then prevention and social determinants of health. So these are some of the things that we wanted to, we don't have a lot of time to talk about these today, but if there's anything that you feel like you want to talk about more, or feel like you can't support at this point in time, and again, we see this not really as a menu of options, we really see this as a package that so many of these planning and implementation efforts and the facilities plans are interrelated. They really affect one another. So we kind of see it as a package. So anything up here that you feel like you would like to have an opportunity to talk about it a little bit more, or feel like you can't support at this point in time?
Looks like everybody's pretty much okay with it.
That's fabulous. That's great. Terrific. Okay.
I do have
so-
one question, though.
Yes, sure.
Not pertaining to the question that you posed. I should have asked this question when Trent was here. With the additional capital expansion and improvement, and then with these recommendations, certainly we will incur additional overhead, right? In addition to a one-time investment or financing option via debt, whatever, certainly we will incur additional overhead. I don't know if you have a projection of how much that will be over and above the current overhead? And also, how are we gonna pay for that? Is it expected to be paid for by the additional business? By the additional revenue generated by fulfilling the capacity, the additional capacity? You see what I'm saying?
Yeah, I know exactly what
Okay,
you're saying.
thank you.
I don't know if I'm supposed to answer the question.
I don't know.
I could talk about how other health systems do it. I mean, a
Okay.
lot of this is absorbed by existing staff. These are planning efforts, and from their own, their revenues, their own funds that they're investing in these kinds of planning efforts and implementation efforts. I mean, JPS is gonna be using its own funds for neighborhood health centers, right, for example. You know,
Let's
so-
say the new behavioral health facility. Once we build it, we're gonna have to operate it, right? Where's that money gonna come from?
I have two fairly direct answers on behalf of the health system. One is, we don't really know how much it's gonna cost. And the answer of how we're gonna pay for it is just most likely the way we have up till now. Meaning, I don't know that there's gonna be some other great resource we're going to discover, but if you look at our data again, our first number is patient revenue from services. Our second number is county funds. So I'm going to take it without the staff's approval to say, we're gonna do it at least the way we are now. The thought in great business plans is you can always do better on the collection side if you have a better facility. But I don't know that we can get real academic in our answer here, other than more than likely, just about like we have up until now. I don't know that we have a better mousetrap.
Is that the final decision of the JPS board?
What, to do these things?
Yeah.
To do those things, but I mean, ultimately, the administration will present
Figure it
budgets
out.
to you guys.
I'm just one member, I'm not about to accept
No, but
that.
they'll present you guys budgets, and you guys will
exactly.
either approve it or you won't approve it, so.
Right. So-
You know, it's just, you're gonna have more zeros at the end of the, you know, I don't know that, let's say if we're gonna use your example, we have more behavioral patients. We built a 250 bed facility, and now we have more patients in there. There's nothing that would tell me, well, the payer mix is gonna change in any great way. It's just gonna have more of what we have, which means that we'll have, you know, more zeros on the end. It's just, the proportions, I think, are gonna be the same, though. I don't,
What I meant is when we open up this new facility,
yeah,
we have 200,000 square feet of new space. That means we have to move some existing employees over.
right.
And then that also means we have to hire additional employees,
Yeah.
right?
Yeah. And what I would suspect they would do would be like most hospitals do. They're going to anticipate, what do we think we're gonna open up with? In other words, if our current census is running 200, and we think we're gonna open up at 225, we're gonna staff accordingly. And if we think it's gonna take us 6 months to get there or a year, then we will proportionally build to that. We wouldn't just.
It's a
I'm sure
gradual-
that they would
okay.
not just say, we're staffing for 250 tomorrow, because they don't know that.
Here's an accountant's
Another
answer.
possibility, Andy, is that to the extent that we're able to divert mental health patients from the county jail to treatment at JPS, then the federal benefits that they lost by being in the county jail will then be available for treatment, to pay for their treatment at JPS.
Okay. So basically, we will fund the additional operational overhead through the additional revenue,
Yeah,
basically.
right.
Okay.
The accounting answer is it's gonna be an economy of scale, right?
Yeah.
Whatever the economy of scale is, we're gonna make a bigger scale.
Well, I was also going to say, I mean, infrastructure is a cost, there's no way to.
Yes.
But some of those items, I lost my talking prompts up there now, actually give us a return on investment, which we're not factoring in. If you look at social determinants of health and prevention, that's money now we won't have to spend
Yeah.
if we do that well. Elder care and patient safety, if we do that well, that'll be a cost that we won't be expending to deliver the care, because we will be now, and that sounds Pollyannish, but that really, I think, is where we have to go. If you look at residency training, and there's a very strong discussion happening well beneath the surface right now for Tarrant County in that regard. So there are, it has to be funded, but it doesn't come out of JPS's budget, but there is money attached, I understand that. But the beauty here is if we train them locally, and if we actually believe we're training them in the model of how healthcare needs to be delivered, they become ours. So we're not recruiting from around the nation, we're training a bulk of, and there's a return on investment of that now, because they already are used to the culture and the mindset. So some of those are costs, but if we do them well, some of them are actually going to give us a nice return on investment of money we won't have to spend into the future.
Right. I bring that up because I remember when Parkland opened up its new facility. I don't remember the exact details, but I think they experienced some negative cash flow delaying their opening date. Something, if you go back and read some of the article on the Star Telegram, it talked about that.
Short-term.
Right, so I just want to make sure that we cover our bases.
Yeah.
Okay, staff?
Okay, so let's move on to the facilities piece. So in your packet, there is a piece that looks like this. You've seen this before, it's been sent to you before. It's a spreadsheet, it has two sides to it. It says new main hospital, then the ambulatory projects, and then the new psychiatric hospital along the left. So I just want to make sure that everyone knows what it is that we're going to be voting on. So if you have that in front of you.
Looks like this, Laura? Check that.
That's it, yes. Blue bar on top. So again, new main hospital, current number of beds is 406.
It looks like this.
Okay. Doesn't matter, I don't vote anyway. There it is.
Who doesn't have a copy? We'll get you a copy. It's in the package.
In the package.
In the question pack.
Okay, great. So new main hospital, and then below that is ambulatory. So it says neighborhood health clinics, so these are JPS medical homes. These are primary care medical homes with integrated behavioral health and perhaps dental care. And we're talking about 4 new health centers in different areas of the county over the next 5 years, with the idea that that would be revisited to determine how many going forward, depending on changes in demographics and needs in different communities, as some communities might gentrify and others might not. The next one is ambulatory on-campus ambulatory surgery center or day surgery. So Trent talked about that. So that's, again, an on-campus entity that would offset the demand on ORs in the main hospital. The next is ambulatory on-campus clinics and support services. And if you took a look at the Cumming report, that included diagnostic and treatment services, that includes the emergency department, administrative and public services, including medical education space, on-campus hospital primary care, so the family practice center, for example, and several specialty clinics. So that's what that on-campus clinics and support services means. And then finally, the new psychiatric hospital. So currently, the number of beds is, actually, it's a total of 132, combination of the hospital and having space in other hospitals and paying for those patients outside, but that's the current capacity. So these are the 5 different facility projects that we're looking at. And what we wanted to do is really have a kind of transparent process, and we wanted to do a round robin and have people indicate the extent to which they support each of the 5 projects. So everyone has an envelope in front of them. Maybe you can hold yours up so you can. Everyone have this. So everyone who's a voting member should have an envelope, and in it is number 1, 2, 3, 4, and 5. Okay, great. And I think we have someone on the phone too, Dr. Trevino?
Dr. Trevino
Okay.
wasn't able to help.
Okay, great. And so how many voting members do we have right now? Is it 8?
I believe it's 9.
9, okay, great. And everyone is around the table, 2, 4, 5, 6. Okay, so there's some people, right, so some people who are not voting. 9, okay.
9. It's
Okay,
9.
who is sitting at the table who is not voting besides the commissioners?
I'm not
Dr. Lowry.
Dr. Lowry.
Dr. Lowry.
Dr. Lowry, that's right, okay, great, okay. Sounds good. So,
You want us to get out?
what we wanted to do is kind of go around one by one, so that it's not a secret ballot, it's a transparent thing, and we want you to either just hold up the number and just say, this is the extent to which I support, and the the rating
Can I
scale.
interrupt?
Yes,
I'm sorry.
yes, sure.
Because this isn't exactly what I thought we were gonna do. I thought we were prioritizing among the projects. What we-
Right.
Is we just say we like them all, I'm sure we're gonna like them all. But the
Yeah.
question is, you probably can't, we're not gonna, I think it'd be irresponsible to tell commissioners do everything.
So-
But aren't we gonna prioritize them? Say we think this one's more important than that
Right,
one?
so what we plan to do is have everyone identify the extent to which they support, and then add those up, and, divide by the number of people here, and then compare those, so that would be a ranking of sorts.
But I don't wanna vote, I don't think you should do it on something just to prioritize it in that way. I guess maybe I'm just arguing with the methodology that you're suggesting.
Yeah,
I think what it would be, I'm just gonna use an example, let's say that I'm a 5 on the main hospital, let's say. And that's strongly support, I think, is the
That's right.
definition. And you're supportive, you think they should, but you're not just quite that strong, but you're supportive, so you give them a 4. Okay, so that's gonna be the differentiating mathematically, because as we go across 5 projects, and if we
I'd
all.
rather give you 1, 2, 3, 4, 5, and let you put up
But they are.
which one I rank first, second, third, fourth, 5, because then it would be a true ranking on my part as opposed to whatever, and then you could add them up that way.
Yeah.
But we're giving a communication to the board. What do we think, you as a board, what do we think is important?
Based on what we've seen.
Right. And so it's possible, we could come back, and man, it's 5s all the way across the board.
Maybe my assumption is we're gonna say all 5 of those are worthwhile projects, just a question of which one you do.
Yeah, I would echo, I had the same concerns. I don't wanna rank these 1 through 5. Somebody's gonna get a 1, and that's going to be very non-representative how any of us feel. But I could see myself, I was actually gonna ask before Dee said this, I could score every one of these a 5. Well, that's great inflation. I haven't done anybody any good in distinguishing. But I have subtle distinctions here, but they're not going to manifest in scoring them this way,
Right.
for me
I think the
personally.
ranking is more, it sounds like more about finance, right? What's more important to put our money into, right? And I think what we talked about was take,
Isn't it need? Are we gonna be focused on,
yeah, we
what
should be
is more
focused on need,
needed?
right? But I think I think these are all needed, and I think we have this.
Let me make a comment or two, if I might.
Please.
I know that we've talked somewhat about saying, okay, how much is this gonna cost versus how much that's going to cost. The charge to the Blue Ribbon Committee is one where that you need to make a determination of the need for these projects. So if you feel like there is a greater need for one versus the other, you need to score it that way. Do not score this because of what you think it might cost or how that might relate to a bond package or something like that, because quite frankly, that's out of your purview. That purview lies within recommendations from the board to the Commissioners Court. The court is going to make that final determination. But what the court is looking for and what the board is looking for is, what do you think that JPS needs to carry out its mission? And if you approach the rankings, or however you want to do your rankings, in that process, rather than trying to calculate, okay, I only want this to come out to be a certain cost. For example, when you look at the main hospital, I know in your chart you have 3 different levels, and it all based on number of beds. And you've heard the reports, and you understand the findings of HMA and the discussions that you all have had at this table. Then what you need to determine is, if you think they need a new bed tower, then how many beds do you think are most optimum to have at this point? Or if there's anything that you might want to have where that you build out a certain number of beds and you shell the floor to, that type of thing. If you don't think they need a new bed tower, well then that's a low ranking. It very well could be that all of these are 5s.
Okay.
And I think that's okay. I mean, to say there's overwhelming support from the Blue Ribbon Committee, or to say that there was dissent on, certain, facility projects, I think that's important, whatever you feel collectively.
So you're not saying that if we vote 5 on the first one. We can't use 5 again.
Right, correct.
You
You
can
can
use
use it all the way
5
across.
all the way
if you
across,
wanted.
you can use 1 all the way across
Yeah.
if you
And
oppose all of these projects.
Also, you said that we should vote what we feel like is the mission of JPS.
The need of the county residents.
Right, but we talked an awful, most of these focus on the main campus, but we've talked a lot about moving that out into the community,
Right, and
moving it
that's-
more out into the community, which
And
only
that's what
one of
this
those.
is. This is,
Right.
so that would be behavioral health and primary care.
Can I
and-
make a statement that may be helpful? Okay. I think it would be helpful for the committee members to look at this from a strategic standpoint, okay? Throughout our conversation, 2 key approaches are necessary for us to be successful in our overall strategic goal, achieving the strategic goal that is. Number 1, we have to build additional capacity to fill the additional needs. But even if we go all out, we won't be able to meet all the needs. Therefore, we have to do things on the front end to curtail the demand, okay? Prevention, ambulatory care, integrated delivery system, and so forth. So whichever one of these initiatives, if you will, meet both of those criteria, to me, would carry a heavier weight because it combined both prong of the approaches. So that's just something for you to ponder about.
And again, we're just rating based on these facilities, right? So the planning and implementation efforts we just talked about before, there was overwhelming support for that. But these are just the facilities, right?
Knowing full well that the ultimate decider, as President Bush would say, will be the board of JPS and the Commissioners Court.
Yeah.
And we're just
Yeah.
So
off.
don't let
Yeah.
commissioners at this point put our thumbs on the scale. Y'all do what you think is right.
Of course, we're gonna do that,
I'm just saying.
for the record.
Well, hopefully, we are giving today's and future leaders, both at JPS and for the county, they've got a roadmap. And you guys are gonna come up with how well you guys are gonna be able to fund it, not us. So if they all get 5s, we didn't say, hey, commissioners, y'all need to fund this right now. We just said, based on the information we saw, this is very, very important.
To me, what you said kind of confused me a little bit, because, for instance, take the main hospital. I'm saying a 5 there, I'm not saying any number of beds. To me, if I'm
Right.
not,
So there are 2
my
phases of
purview
this.
is not a financial issue,
Right.
of how much you're gonna budget to that versus this, then that to me doesn't qualify that I'm saying I want X number of
Right.
beds. It's
Right.
just, I think, yes, there needs to be a
Right.
new hospital.
Right.
Depending on the finances and the budget, then whether that's this size or this size, is not
So
my
we're gonna
purview.
have 2 exercises, actually. This is the first one, where people just rate the extent to which they support each of the 5. And then we were gonna take these 3 down, and we're gonna look at the main hospital and the psych hospital, and we're gonna look at bed sizes. Because some of the recommendations and ranges are different. You know, you could build a modest-sized hospital, you could build a larger hospital, you can build a very large hospital. So we were gonna take you through an exercise that focused on size as well. But for right now, we just
Gee,
wanna
that's
look at.
No, I'm fine, no, I'm not gonna be there. I'm still just not following this, but I'm with you. I mean, we'll do it, I'll follow the game plan.
Okay.
Seriously though, do you have an additional question on that, Dee?
My question is, how could we not, after what we've seen through, give 5s everything? It just seems like a statement of the obvious. I don't understand, but maybe we just need to walk through it and do it, I guess.
Well, you very well could all give 5s, but we don't want to presuppose that everybody
That's
thinks all of these are 5s, okay?
Okay.
But it's okay to give a 5, that's the importance of this collaborative effort. I mean, tell us what you think.
Dee,
And
but
if you think all 5, then that's good.
But Dee, ultimately, in the end, what you wanna come out is with a prioritization.
No, but if that's not what the Commissioners Court wants, that's fine. I mean, we'll just give them what they want. I understand that.
Right.
Right.
So a report on your behalf, we need to know what you support. So why don't we start with you? So just put up, and. So what we're gonna do is, we're gonna go through,
Well,
5 rounds. This is the first round, we're just focused on the new main hospital, yes?
I mean, just for the efficiency of the committee, now Mark just said he's gonna give 5s to everything. Okay, don't let me put words in your mouth, but I thought I heard you just say. So why not just go ahead and put it
We
across
could do
if
it
he
that way,
knows?
or
If he
we
knows.
wanted, yeah,
But now, let's say, though, that Dr. Flynn says, well, I'm not ready to do that. I'm ready to just do the main hospital.
then I think we'll get
Then-
confused.
No, I don't think so at all. No, not at all. You've just taken care of Mark. You've just taken care of it, okay?
Yeah,
So now Stuart says, you know what, I'm different than Mark on this. I actually don't have all 5s. So I'm going to give you the 5 on the main hospital because that's the way I feel. Okay, and then we're gonna come over here to Dr. Hesball. And then he's gonna do whatever he does and whatever. But for those that know, I'm giving everybody 5s. Well, let's go ahead and get them on there and we don't have to waste a lot of committee time on, okay, let's do years. Yeah, I already told you it's a 5. You know what I'm
we could
saying?
just do it, or we could do it quickly.
You know?
Yeah,
Does that make any sense?
unless we wanted to give people an opportunity to say
Okay,
something
well,
about,
okay, well then
vote.
I'll back up a second.
okay.
Is there anybody here, you don't have to tell us what it is, but is there anybody here that
That's a
has
great
anything
question.
other than 5s?
That's the question.
So we just saved ourselves a whole bunch of time. Is that right? Or does anybody have some 4s or 3s? I mean, which is okay.
Good job. We have plenty of cookies to pay, y'all. Take all the
Boy,
time you want.
Scott keeps me going here, you know?
Well, I think I'm maybe not to speak for Dee, but I'm internally, because of course I have to grade young people, and I'll get yelled at if I give them all A's. I'm internally trying to calibrate, but the reality is these are all, so the one I would, don't write this up here because I don't want it to be a 4, but if I had to calibrate internally, I would take the ambulatory surgery center and give it a 4. However, that immediately impacts on the hospital.
Exactly.
So
Exactly.
externally, I don't want to do that, but I think what Dee's doing a little bit, I'm trying to internally not give everything a 5, but if I'm gonna, with your charge, I would give them all a 5, and I can defend that across the board. And I struggle to give a 4, but if you said you have to give a 4, now I could give a 4.
Yeah, that's why we didn't wanna box
Understood.
people in.
And that's why I think
that,
Dee's
yeah.
question are we, so we internally are ranking these, there's no, I know what my number 1 priority is, and it isn't where I started on this commission.
Oh, good.
But they're all a 5,
Yeah.
so you can't tell
Yeah.
by my scoring which one's my
Right.
number 1 priority.
Right, exactly. Okay,
And I
so,
think we just wanted to make sure when we're talking about this, prior to ever coming to this point, was we did not want to, I think, GK said, presuppose.
Right.
In other words, we didn't want, let's say that, there was somebody that just said, oh, it's all 5s, and it's, oh, okay, I guess if he says all 5s, I guess I better do all 5s. No, we don't want that. We want true input. But the true input, I have a feeling, because I'm like you, I'm 5s all the way across the board. All of these need to be done. And some of them are desperate, but some of them are not desperate, but they're very important, and they're just as important as the ones that are desperate. You know what I'm saying?
Yeah.
So,
okay,
but if there are others, I don't want to cut you out. If you don't think that way, then you're part of this whole community.
right, so let's just go
Representation.
around just one by
Yeah.
one, not for each one of these, but
Yeah.
for the group of facility projects.
Yeah.
So we started with you held up a 5 for the new main hospital. How do you feel about the rest of them?
All 5.
All 5s, okay. Any comments that you have about them, or you're good? Okay, and we just heard from you.
I'd go all
Same
5,
thing.
and my number 1 of the 5s, we weren't asked to do this,
But feel free.
is the psychiatric
Okay.
hospital.
Yep, okay. Yeah,
I'd echo the same thing. They all, after all the presentation and the data, I can't help but say there's 5s for every one of them. It's the prioritization and the budget that
Right,
we're
that's
not,
gonna be
it's
the-
our purview, so
Sure.
I'll leave that to the board of how to, whether it's mid-level or high level, because they all affect every one of them. However much the new utilization depends on how much is being delivered in remote areas of the
Right,
county.
right, exactly. Okay,
LCM, 5 on the new main hospital, 5 on the ambulatory, 4 on the ambulatory surgery center, 4 on the on-campus clinic, and 5 on the psychiatric hospital. You paid me well, Wayne.
okay. And if, again, as we go around, if you're like, I can't remember what's included in the on-campus clinics and support services, take a look down at that sheet and it explains what that is. Okay, Randy?
So I'm fives all
Yep,
the way
that's
across,
what I heard.
and I'm putting an asterisk on the new main and the new psych, because I think those are desperate.
Okay, great, thank you. Yes.
I do 5s on all of them, and I would be torn between the main hospital and the psychiatric hospital on the number 1 priority.
Okay,
I'm sorry, could you say that again? I apologize.
all 5s,
I guess you can figure out I'm gonna go all 5s.
yeah.
And with the 2 commissioners here and GK here, I'll just say, it hurts me to do all 5s, but, y'all heard my reservations, so that's good. They
You
can
make
make,
choices, Steve.
no, I don't, ultimately, I think they're
Yeah,
all
we
very
all want-
laudable goals,
yeah.
and the
Yeah.
county's gonna make a decision on how they go about that, but
Great. Okay, we're skipping over Roy, skipping over Commissioner. Yes,
TRL, all 5s.
okay.
Okay.
Any comments or
No.
thoughts? Okay.
Well, everything up there is critical, and everything up there, I would say I would very much be in support, and they all affect each other. You know, if you don't have the
That's right.
ambulatory surgical center, you will affect the operating rooms of the new hospital. We've already seen that whenever it opened. We were almost at capacity. I was there when it opened. And so those types of things, they're so interrelated in everything here. So I would have to go all 5s across the board for all of these items.
Okay. Okay, so any of the non-voting members want to say anything about?
Well,
Each
thank
of
you
the-
for making our job harder.
I tried,
Anything you
I
did
tried.
Thank you, Dee, for your good intentions.
Well, the other liaison spoke, I want to take half a second to tell you that given that it's going to be hard enough to get this elected in this county, I can't imagine going forward with any thought other than, you know what? We need all of this. Because if you say, well, we need this more than that, no, it's just not worth the effort. We need all of this, and you folks have done a nice job of saying that. And there's a whole psychological study on people who don't like to give all 5s and all 1s.
Lawyers?
There are A-type personalities and B-type personalities. We have some Bs, we have some As, and I want to be analytic. But thank y'all. It says you see the importance of what we're doing. Thank you.
Okay, so at this point, we're going to take down these, and we're going to put up those other, let me see if I can, we're going to start talking a little bit about sizing.
Opens a suggestion on this as well. There's really a hypothesis that as we're thinking through the sizes, there might be variability on the conviction of the number that you are choosing amongst these. So the idea here, instead of giving a 1 through 5, is just to check off the one that you're voting for. And I'll put a small, medium, or large check next to that based on your conviction. That you really feel strongly about this, or, yeah, I'm willing to put up that number and put a vote towards it, but, you know, I'm not well convinced that is the number. So kind of a small, medium, large check mark next to the one that makes sense.
Just as a reference point, one more time, today, we have how many beds?
So Greg, you should probably go through this sheet that
Yep.
people were looking at, and maybe you should talk about the difference.
This one.
I think it's right here.
Can we have Mike, please?
Mike, yeah, sure. Thank you. All right, well, let's talk about the acute side first. So just a tad over 400 beds right now. A
analysis that bed size, that number of beds, could fulfill 37% of the need for adults under 250 FPL. So that's about where things stand now, and bringing that forward and thinking through 20 years, and Tarrant County as a whole, and JPS in particular, through population health, is able to manage down the number of bed days. So that's two ways: preventing admissions, and once there is an admission, squeezing down the number of days that people are in the hospital. And Tarrant County as a whole is in around the 50th percentile, and there's a general feeling that that can come down. There was previous estimates by Blue Cottage that that might be 10%. We had in there getting to a further stretch goal as a county to 20%, and that would put the need somewhere between 596 on the low end and 664, just to stay where you are now, at that kind of 37% with the population growth. So somewhere between 596, really that taking on the population health and driving down, just to stay where you are over 20 years. So 596 or 664 are kind of two analytical numbers that were out there. As far as on the building side, there's plans, and we have kind of pricing and a choice at the 496, which is kind of the lowest with 120 shelled beds. So, room for expansion in the future, but really building towards 496 currently. Or the second choice here is 616 beds, which is a build-out of those 120 beds. So kind of saying, 37% is not enough. We got to, get more in there right now. Or really, looking at that future 20 years from now, and knowing that it could be 664 if we look at the Blue Cottage and the 10% reduction, and looking at an additional 60 beds.
Is there no other shell space option other than the first one?
So on the pricing and what was kind of, looked at, these are unshelled, these two. So they don't have shelves. There definitely could be more options, and that gets to a point that, some of this is kind of communicating priorities against what was, presented by, the infrastructure costing. And so there could be other options, but that's what was priced and what we have on the table. So in a similar way, I think we should go around, kind of cast a vote, whether that's a small, medium, large, kind of check mark based on your conviction, and speak to that for up to a minute. Just kind of say why you're voting for what you are. And we'll start with the main hospital. Can we start you off again?
Just to do one thing, right?
One thing.
Either small, medium, or large check mark on which one I want.
Yes. What you think when community needs, and from all the information that we have at hand to date.
Right. And we're just going to the main hospital, and we're going to come back to the psych hospital.
Then we will. Yes, we'll do that next. Yes.
So on the main hospital, I would just give a large check on the 616.
On the 660.
Finish out the size.
All right. And anything you want to say to that, or just?
Well, I mean, that fits the demand, in my opinion. There's, when you're gonna go ahead and build this thing, just finish it.
Okay.
Get the use of it, get the utilization of it.
Yep.
I'm not a big believer in shell space unless you're gonna really build them. Well, I'm just not a big believer in shell space.
Okay. Excellent.
Yeah, I'll start by echoing the shell space. I think that's a little bit of a bait and switch in many ways, so I would prefer to stay away from that. I think 496 would be the optimal if we were actually successful in keeping patients out of the hospital, and I'd like to think that's where we're gonna go, but I'm not willing to risk this county the beta test site for that. And I'd have to echo Roy, as much as he doesn't want me echoing him. If you're going to do this, and we know the population of this county is going to explode.
Exactly.
And we're now looking at a hospital that was built 32 years ago. And we're talking 20 years out, so we're already gonna have a facility that is already now, we're looking at and saying it's aging. I just would, I hate to say it, the commissioners aren't gonna invite me back, but I'd have to put a big check near this 676. I have to be a pragmatist in this.
Excellent.
What you talked about before, maybe on top, so people can visually see that, because these bed numbers are not the range that we talked about. These are just numbers that were priced.
Of the future need?
Yeah.
Okay. So the anchor kind of numbers that we have is 596. That's getting to, on Dartmouth Atlas, which kind of rates community areas across the U.S., this would be getting into the top 10% currently of all communities. So that's a real stretch goal to kind of squeeze down to that 596. There's reasons to believe that. Hospitalizations have been decreasing across the U.S., and there's opportunity here because you're at the 50% range now. So
And that's in 20 years.
that's in 20 years.
That most aggressive
Right.
reduction in.
Also,
admissions and like that.
to be fair, also 37%.
Yeah, well, the note says that the range is from 594 to 664. 20-year estimates.
Yep. Okay. So I have 596. I had just done the math again instead of going.
So
Yeah.
it's
Yeah.
594 to 664. That's the range. Am I reading that wrong?
No, that's correct. Yep. I have 596 incorrectly here. Yes.
So the range would be 594 to 664.
Right. 664. So 664 is really looking at. So that's a 20% reduction in hospital days, which could be done by reducing length of stay or reducing hospitalizations themselves. And that would be a 20% approximately, versus 664, which is a little over 10% reduction. So kind of giving you that range. But they both include significant improvements over time in hospital days, and they both are kind of keeping you at the same level, it's 50% of uncompensated. We saw that before. This is more than just, this is not just uncompensated. This is adults under 250% FPL. So those are two different numbers. But it gives you a sense. This is, 37% capacity enough to serve 37% of those under 250 FPL. That's the anchor number here.
So that's the
45%
range, recommended range. Those are the two outer ones. Just to normalize it.
Okay.
You said there's currently 400?
402, yeah, right in there. 406, there you go.
Are those
Two-
licensed beds?
2s and 4s and 6s are giving me trouble.
Okay, so that includes all the semis too, right?
Well, these are all private.
No, no, no.
I'm sorry.
What you got now?
We have
What you got now?
409, that includes semis.
Yeah, okay.
I think I would go with the middle numbers, 16. I think we have to look at the future, but also knowing that this is a level 1 center, it's the only one. I don't see any of the other hospitals really stepping up to become a level 1, but I do see them trying to increase their bed utilization. They're in competition as well to some of those payers and quality, so I would go with the 616.
Small, medium, large?
Medium.
Medium.
616.
Yeah, and so the other piece of this that may or may not be helpful is thinking about the size of the check mark, which is the degree of your conviction around that.
I'd like to change the size of it.
Dee, we're gonna have this all.
So these are high convictions at these
Gotcha.
numbers. Would you Would you keep it? Would you keep it there?
I'm not gonna waste our time.
Fair enough, fair enough, fair enough. But
Just leave my check mark the same as his.
you got it, you got it. Put it right there, all right.
That's smaller.
I'm gonna go with the 676.
Okay.
Based on, my gut tells me with what we've been reading, that we're gonna have in 20 years a population explosion. And then going and seeing people wait, that's just unacceptable and unhuman. So a big check for that one.
Okay. And do we think this big, small, medium, does that matter, or should we just say, doesn't? Okay, so we're just gonna go with checks, all right, fair enough, fair enough.
616.
You got it. Anything to,
No.
okay.
I'm so confused. All those numbers.
Yeah, it
And
is a lot, yeah.
I
yeah.
don't know what a shell bed is.
So,
Shell
so,
floor.
so the shell bed would say, you know, basically you're gonna leave it empty for some period and be able to build into it
Build out
later.
later on,
Yeah.
yeah.
So, so there's, it's about, you know, I was looking at the numbers, and don't hold me to this, but I was just looking at various estimates, and it looked like, you know, it was a significant piece of it is building out the shell space, 45, 50, a big piece of that. So you're saving some money by not doing it at first, potentially. But other points about why would you build it if you're not gonna actually, well, you're gonna spend 50% of that capital and not actually
And you
use
pay
it.
more when you build out the shell
Yeah.
space.
Yeah,
so you
because the
pay
costs go up
more.
over time.
Exactly.
So there are
And it's just harder to build in addition.
Yeah.
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 And you
There-
have to go back and find some more money.
Exactly.
Yeah, yeah,
GK
yeah.
will be hosting another.
Yeah. There are strong,
No. But Dee will be happy to sit on it if you do, so.
yeah, we could list out a whole bunch of reasons why. Yeah.
Well, let me give you the con point of that, okay, as an old hospital administrator. When you couldn't get all the money you needed, if you could get it shelled, you knew you had a much better opportunity later on down the road of getting it finished, because the cost of the finish out was so radically less than,
And the new.
yeah, and the other thing too is you structure your building so that you can easily handle that at the point of construction as opposed to later on. That way you've actually got all your stuff. If you end up saying, well, you know, we missed on this and we really need to put another floor on this, boy, the unknown expenses going back in are really, really tough. But I mean, I respect all y'all's opinions on that, because ultimately it ends up being a budget thing that allows the commissioners and the board to have a little bit of flexibility. That's it. It's a
Exactly.
financing deal. Yeah.
And in the end might be needed to
Yeah.
make that
Because they may
ball work.
come back and say, you know what, you guys, you're right, we need the 616, but that one extra floor, if we could shell it, we could save 50 million, and then we can go get our ASC with that. You know, I mean, they may have to come up with those sorts of decisions, so, yeah.
Thank
Drum
you
roll
for,
for Sarah.
thank you for confusing me.
Sorry.
I'm gonna go with the max. Don't ask me why, please.
When was the last time beds were added to the main facility?
2008. 2008, yeah.
2008. We're in 2017, so basically 9 years ago. I'm unmoored from economics and pragmatism. Big check at the bottom one. I mean, you're there, do it. That's for you, Commissioner.
Oh, yeah, sorry, yes. Miss Leggett.
Oh, it's my turn. Okay, I'm gonna do a big check for 676. The last bond was in 1985. We added beds in 2008. So obviously with the population increasing at the rate that it is, and if we don't want to continuously to have these conversations, the fact of the matter is Texas as a state, Tarrant County as a whole is growing rapidly. Jobs are coming. We talked about this over and over again. And then there's a population of baby boomers that are going to need these beds soon as well. So I think don't wait on it and let's not have this conversation again. And if we're gonna wait that long, over 30 years, to have another conversation, then let's just go for the max.
Excellent.
Well, I think you currently need probably at least another 60 to 80 beds right now as it sits, because they're always full. And that's, the
Right.
course that you hear is that, well, we're backed up, we don't have beds, our ER can't get you in fast enough, or surgery. All of these things, there are so many things that they may not grind to a halt, but they come to an extreme slow when you don't have beds and you can't get patients into beds. You absolutely need 676. How you get there, whether or not you build 616 and go to a shell for the rest, which is not an option, so I'm not gonna pick that option. But whether or not you do that to save money, but you better plan for that 676 as a big check mark.
May I ask a question? Does the 676 get us above the 37%?
By,
If it does,
yeah,
how much?
by doing those population efforts, population health efforts and efficiency, can get it to 664, somewhere between 594 and 664 to do the same percent of the population. So the answer is yes, that gets you covering the same amount in 20 years.
You're all good. You're all good.
Excellent.
It is
All right, fantastic. Let's move over to the new psych hospital. Oh, short on time, okay. So 132 beds currently. Some of those are licensed beds. The plan was 148 with shelled beds at 50. What we have on the table really is a build out of 198 or 298, knowing that this is the estimate that we've seen, which we're not talking about cost now anyway, so that's fine, but that was more of a quick estimate that needs further analysis. Why don't we, oh, and the need, so, in a similar way, what was the need here? It was 516. Again, when we look at, that's the 20-year mark, and that is also assuming major efforts on the population health side and integrated delivery system for behavioral health, with this number being 50% of a 50% number. So it's really kind of a much lower number than what is out there in the literature of need for public psychiatric beds per population. But 516 is kind of the HMA suggestion of recommendation of where to try to get to, and the what's on the table is to fulfill two different kind of proportions of that need. 198.
Neither of those actually be in HMA's recommendation, just to be clear.
Right.
Those two numbers were
Right.
not the
This is kind of what's out there on the building side and what's been brought to the table thus far. Yeah.
Wayne, how many do we contract out now?
So we contract on a per day basis, and so it fluctuates and varies. We've had as few as a couple and as many as probably 30 people in beds in the hospitals currently. And all of those 132 beds, for clarity, we have 132 beds that are licensed in our facility. So the contracted beds are in addition to the 132 that we currently have.
Those 132 double rooms?
They are all semi-private rooms.
Okay, so a lot of those
A lot of
you
them
can't use.
I lose about 10%. I lose between
Because you can't
between
put two
12 and
people in
15
a
beds a day that
room.
can't be used.
That's fine.
And are these single room?
These
That
would
that
be.
you're discussing?
Yep. These are both estimated at single room buildings. Ready?
Check mark on 298.
298. Okay.
Can I ask one more question? Wayne, okay, so you said that we lease on a fluctuating basis between 5 to 30, anywhere in there, is that right?
Correct.
And where in the numbers are the patients that are related to the justice system? Is that part of that number, or is that still another?
So that's a different piece. So currently, we don't do any local competency restoration. So anybody who's unfit to proceed with the criminal trial would go to the state hospital, or not, as it currently is in Texas, and typically stay in the jail awaiting a bed in the state hospital. even if
Okay,
you're-
so that wouldn't impact us in any way?
No, sir.
Okay, all right.
So that doesn't even include them at all?
No, it does not. No, if you wanted to address that part of the population, it would have to be an additional number.
Yeah.
Or if you, and this also did not include substance use disorder beds.
I'm sorry, what was that last sentence?
These did not include substance use disorder beds.
Oh,
So people with a primary substance use disorder as opposed to primary psychiatric disorder, the bed count did not include that population.
Which
How
adding
big is
that
that
service is
population?
something we're recommending.
Yeah, so
Is a
currently-
recommendation.
Correct, so
Currently, JPS does not deliver primary substance use disorder services.
we don't do any substance abuse there, and so adding that is part of the recommendation. And so
Yes.
then you've got to factor in, okay, what are we gonna do with those folks? Where are they gonna go?
But that's not part of either of these bed counts. Is that a fair comment?
That's correct.
That's fair,
Okay.
yes.
How big is that population on a daily basis?
We don't treat them, so I wouldn't be able to estimate it based on our experience. So we would have to probably look at what trends in communities look like.
So you're saying they would not be part of the 298 beds if you're doing
That's
substance
correct.
abuse? Where would they be?
So, well, this is based on the projections of the psychiatric beds, and so that would be a different number that you would want to calculate based on what the substance use beds would be. I mean, in theory, you could license those beds to treat substance use disorder, but then you begin to shrink the capacity that you've intended for psychiatric care.
Have you seen that there's a crossover there, that people maybe are admitted for their psychiatric issues, but when you get down to it, there's a substance abuse? and that
We
they-
do experience quite a bit of substance-induced psychosis and other conditions, behavioral health
So you
conditions.
basically treat the psychosis and then they're released because we can't do the substance.
We try and
abuse.
connect them to substance abuse, but we don't do it ourselves.
Right.
Okay.
And I would say there's probably a gap in the community.
I would say I don't think you can differentiate completely the two and say this is only substance abuse, this is only psychiatric, because
Sure, right.
they are in there a lot of times because of decompensation, because of substance abuse
Exactly.
or some other issue.
yeah.
That gets better and they get released and they don't get any treatment for the substance issue. Then they're back
Back,
again a month later.
Yep,
So the two really you have to think about together.
absolutely. Yep, and certainly in terms of prevention and kind of an integrated system needs
Right.
both, yep.
You snuck your vote in.
I did, we'll do that.
I would echo that.
Any comments on it?
Just overwhelmingly depressed that this is where we are, but we need to deal with it, so.
I'd agree.
I forfeit because I think this is an unrealized demand. It's larger than we think, and so. Ditto.
Any comments?
No.
Ditto.
Comments?
No, it's aspirational, so absolutely, it's things we can put forward.
298 as well?
Yep, you're right, yes.
Okay,
Yep.
298 as well.
Yep.
My comment on that is after researching and watching online the feedback from the community, it was overwhelmingly
Right.
wonderful feedback about the psychiatric care. And there was one person who stood out in my mind as she talked about her daughter who was a nurse and has many psychiatric episodes and had no place to go. And she just reiterated the need, and there's people who are unable to, not only unable to afford, but when it comes to trying to get help, there isn't enough support out there. And she wasn't the only one. It was testimony after testimony in different precincts where people were in support of this. So I say 298 with the backing of our community.
298.
Comments?
Probably such that, as I've learned, beds can be licensed either way, as Wayne has said, and having that capacity allows you, I'm guessing, to modify what you need, substance abuse beds versus general psychiatric beds, is that?
It is, you can certainly do that.
Chief, we're missing, I think, two important voices here with the two pastors that are out. Is there any way that we could get their input?
Sure. We just need to, we have to go through this exercise with them. I mean, we have to do that, if that's the desire of the group.
What do you think? I mean, I don't know the reasons that they're not here today, but certainly they've been through the bump and grind here and have some opinions.
Well, Scott, of course, has been sitting on the board, or has sat on the board. He's not, I guess he's off now, so I would think he's well-versed on all of this. So it'd only be Pastor Evans that that we might get something new, and I don't know, maybe we need to just share these findings with him, so we don't have to bring the whole committee together, and then
sure.
see if,
Well, I'm not
see if
asking
he's
to bring
in
the whole
it.
committee,
See if
just
he's
somebody
got any,
just touch base with
see if
them.
he's got anything.
Okay.
So is
Yeah.
that something that the chairs would like to do, or do you want to leave that to staff? We can do either way.
I mean, I feel comfortable doing it. If you want us to do it, I can, or you wanna together?
We can do it, and with a staff person with us to make sure we,
I actually would prefer that the co-chairs would do this.
Okay.
anything you want
All right, well, fantastic, yeah, go ahead.
Randy, did you want to make some kind of comment?
No, other than, I think you guys have done great, and, now we've really starting to get this to a manageable point. So, no, if you want to kind of tie it all in a bow here for us, Lori, but.
Yeah, I think the results speak for themselves. I mean,
Yeah.
overwhelmingly supportive of the planning efforts,
Yeah.
all the facility efforts, and it looks like the largest, options for the new hospital in such a location. So, I'm very happy.
Yeah.
GK, any comments you'd like to?
No, I know that this is the messy part, quite frankly, in all of these things, is trying to determine what's more important, what's not as important, what size and things like that. And if you go away from this meeting today feeling that, you got everything that you thought you needed to do, or if you felt a little uncomfortable about it, well then, both of those feelings are really pretty good, because that's what happens in these type of situations. Just a general comment from staff, and you're gonna hear that a couple of times. When you look around this room, and you look at everyone on this committee, and the leadership that the co-chairs have provided, but the input that you all did, I know that the court's gonna make those comments, but I will tell you that it has been very impressive working with you all on this. And I've worked with a bunch of different committees like this, and you bring a diversity of views in it, but you coalesced around what at least some of us think are the important things and the sizing of those things. So from staff level, we want to tell you, thank you very much, and don't take my comments as being that this is the last meeting, because now we get to write the report, and you all get to put your mark on that report. But it's thank you all.
GK, if I could add one other thing, and it's actually to echo something that Dr. Flynn said. I actually came into this process with a different thought that I thought I was gonna go. And so I have to really compliment the JPS guys for educating me, and I thought, hey, I kind of have an inside knowledge of what was going on over there, and I quite frankly was quite surprised in a positive way. Because I thought I was going to be much more of a critic than I have been. I've been more impressed than anything else. And then the committee, you guys have been fabulous to work with, and I appreciate. I think you have helped me have a broader view of the need for us to go through with this. I frankly got into this thinking, man, how am I ever going to sell anything to the community, and I'm coming out of it saying I am more than happy to sell this program, and I can easily defend this no matter who I encounter in the community, which I know we're going to encounter some, for sure. But I think we have done a great job of investigating all of this, and it's going to be an expensive price tag. I know that for sure. And thank you guys for bringing us this data. This is really complex stuff, and you've been able to try to get this down to where we could all understand it. This is a lot of data. And then finally, GK, to you and all your staff for making it as easy as possible on us, because it was a lot of work on everybody's part. So I'm just impressed with everybody. Y'all changed my mind. Yeah.
And I just wanted to say, I have, for a number of years, worked on healthcare in the Congress. And you talk about a mishmash of crapola. But our process, I was sitting here and I talked to a friend of mine that did the Energy and Commerce Committee, and she was the staff director, and her main job was healthcare. And this was back when Tom Foley was the speaker. And we met every Thursday at 2 o'clock for 2.5 hours to talk about healthcare. And we came up with all kind of plans. Everybody had an opinion, but the only reason we couldn't do a healthcare bill, and that was back in the late 90s, early 2000s, because we didn't have a president that would sign it. But the process was so convoluted, and I wish that Karen could sit in the room and have watched our evolution through this process. I think she would have learned a lot, and our processes. And then now you sit and you look at, I'm riveted to the TV to watch how the Congress is doing it now. Oh my God. And the politics. I would imagine that there's no, I'm hoping that we've come away from this, not from a politics, Democrat, Independent, Republican, but what's good for the residents of Tarrant County.
That's right, period.
And if we can walk out of this door and say, I voted for this because I believe this is going to help my neighbors.
That's right, period.
Then this is a good thing. But if we feel that we've done this out of political stuff, of which I don't believe, then I think our work is good. And Wayne, paid to the order of Lorraine C. Miller. It's been great working with you.
Thank you. Same here. Same here.
You're
Been a
nice
great
guy.
co-chair.
Yeah.
Remember, guys, we're still meeting.
Well, I take back everything I said.
And thank all of you, because it's because of you that this has worked, because I was a little skeptical when my commissioner called me, but hey.
If I may,
Yes, sir.
I want to thank you all for participating in this process. It is an extremely valuable process for the people of Tarrant County. And let me just say a little something about politics. County government is different from the federal government. Because we have to perform regardless of the politics. So we try to avoid the politics, don't we, Andy? As much as we possibly can. Invariably, there will be some items that are just political on their face. And those I'm gonna lose 4-1. But most issues that face county government are not partisan in their nature. They're about what's good for the community, what's good policy, what's the best way to provide the services that we're charged with providing. And this whole process mirrored that philosophy.
Okay. All right, thank you all.
Thank you. I enjoyed it, man.
I know.
We're gonna see each other.